frequent use of medications in severe BPD, despite lacking pharmacologic or clinical research evidence, reflects an unmet public health challenge. This is our roadmap. Before focusing specifically on severe BPD, we'll review some of the challenges of neonatal pharmacology. We'll then take a focused look at medication use in infants with severe BPD. And lastly, review the clinical research evidence to support their use. There are many challenges to developing neonatal pharmacotherapies. These are just a few. Relatively speaking, the financial incentives are small. Pharmaceutical companies seeking a return on investment are incentivized to develop drugs for large markets. We are not a large market. Many of you, I am sure, are very familiar with the added ethical and regulatory hurdles to conducting high-quality research in neonates. And what I'd like to focus on a bit more in this talk is how the pharmacology and physiology of neonates creates unique challenges. We all know that when it comes to medications, how much matters. Paracelsus, the father of toxicology, reminded us that all things are poison and nothing is without poison. Only the dose makes a thing not a poison. And with respect to how much medication to give the infants that we treat, we should all strive to be as discerning as Goldilocks. Not too little, not too much, but just right. Too little medication is ineffective, too much medication is toxic, and the space between the therapeutic index is the sweet spot that we are all aiming for. I promise not to bore you with too much pharmacology, but if you'll bear with me for a little while we review some familiar concepts, you can think of pharmacokinetics as the effect that the body has on a drug, and this plays a critical role in determining just right. So, what does the body do to a drug? Unless it's given intravenously, the body has to absorb it, typically through the gastrointestinal tract. It is then distributed through different body compartments, depending on the drug's affinity to circulating proteins, fat, and water. Metabolism, often a hepatic function, breaks down drugs, frequently inactivating them and facilitating their elimination, which is achieved through excretion, often through the kidneys. All of these processes play an important role in determining whether the amount of drug you prescribe an infant with BPD is just right. A critical challenge to neonatal pharmacology is that the processes which determine just right are dramatically influenced by disease and development. And what is neonatology if not the management of life-threatening disease during a period of dynamic development? If you ask the experts what makes neonatal clinical pharmacology different from pediatric or adult clinical pharmacology, their response is that you are aiming at a moving target. And infants with severe BPD are a perfect reminder of just how far that target travels in the hands of neonatologists. Both of these infants are routinely cared for by neonatal providers in the same NICUs, referencing the same neonatal formularies. But just as children are not small adults, 6-month-old infants with severe BPD are not big premature infants with RDS. We can't think about the respiratory management in the same way, and we can't manage their medications in the same way. Yet, we often do. So let's look at a few concrete examples of these processes on the move. Absorption depends on various factors, such as the intraluminal pH and the presence of bile acids. These physiologic processes develop rapidly between birth and 3 months of age, both more than triple. What about metabolism? Look at the dramatic maturation of hepatic enzymes involved in drug metabolism. Those of us taking care of infants with severe BPD are over here, taking care of patients with a physiology that is sometimes more similar to school-aged children than the young premature infants that are often the focus of our training. What about excretion? Furosemide is a very commonly used medication in infants with severe BPD and my current research focus. So in part due to strong albumin binding, furosemide has very low glomerular filtration and kind of just skips on by from the afferent to the efferent arterioles and into the peritubular capillaries. Where at the level of the proximal tubules, it is stripped off of albumin by its very, very high affinity to organic acid transporters, and here actively secreted into the renal lumen. It is this tubular secretion that is critical to both its elimination and its therapeutic effect. But tubular secretion, and in turn furosemide clearance, is developmentally mediated. So as this graph shows here, renal clearance increases exponentially after birth. And in those infants with severe BPD, over here, is very, very different than younger preterm infants. So all of the factors that we've discussed over the last few slides should influence and inform dosing strategies. We've focused on how development complicates getting medication dosages just right in severe BPD, but let's not overlook the impact of disease. Many infants with severe BPD are given a trial of post-pyloric feeds as a theoretical lung protective strategy. In addition to feeds, route of administration also impacts the bioavailability of medications. Furosemide, for example, undergoes significant absorption in the stomach and may be absorbed differently if it's given post-pylorically. Infants with severe BPD often have poor motility. Some of our infants have comorbid surgical neck and are missing large portions of their intestines. Cholestasis from TPN-associated liver disease is common and decreases the availability of bile acids. All impact absorption. Our infants often develop profound edema. This drastically alters body composition and volume of distribution. Adequate nutrition is a challenge in severe BPD. Hypoalbuminemia is common. This also alters the distribution of highly protein-bound drugs such as furosemide. And lastly, both liver and renal failure can complicate severe BPD, particularly during periods of critical illness. So please allow me to emphasize that appropriate care in severe BPD requires tailored care, and that this concept most certainly extends to medication use. Okay. So in this next part of the talk, we're going to get a bit more concrete and talk about the medications we actually use in infants with severe BPD. And I'll start by justifying why we care so much about severe BPD. Why did we at CHOP build an entire program dedicated to this population? This is a wonderful graph from Ravi Patel and colleagues showing us, at least in the United States, how the cause of death in preterm infants and changes across postnatal age. So RDS, okay, so here we have the proportion of deaths, okay, and here we have postnatal age. So RDS predominates over the first couple weeks of life, and then for a period of time gives way to NEC. But beyond 2 months of life, BPD, shown here in red, is the predominant cause of death in preterm born infants. BPD also leads to developmental impairments. Some of you may be familiar with this figure by Barbara Schmidt, showing the additive impact of brain injury, severe ROP, and BPD on the probability of death or developmental impairment at 18 months. But among these key morbidities, BPD is far, far and away the most common. In fact, it is 3 to 4 times more common than the other key major morbidities. And lastly, unlike other morbidities, rates of BPD are not improving, in large part because of the increased survival in the most premature infants. It's also important to emphasize that BPD occurs along a very broad spectrum of disease severity, and that this disease is particularly burdensome in infants with severe BPD, which I consider both grade 2 and grade 3 BPD for the purposes of this presentation. So if you remain on mechanical ventilation at 36 weeks postmenstrual age, consistent with grade 3 BPD, survival to infancy without serious respiratory morbidity or developmental impairment would be defying the odds, which serves to emphasize the importance of identifying useful interventions in this population. When I first joined the chronic lung disease program at CHOP as a trainee, one of the first things that really struck me was the sheer number of medications our infants with severe BPD were routinely exposed to. And why is this the case? I would argue that it's mostly a combination of 3 things. The first is that our babies are very, very sick. They're also with us for a very long time. And the urge to do something is often very hard to resist. We want to help, and we feel compelled to act in some way. We wanted to better understand medication use in severe BPD. In the next few slides, I'll present research that was published in 2019 in the Journal of Perinatology. Our objectives were twofold. First, we wanted to better characterize just how many different medications infants with severe BPD are exposed to. And second, we wanted to support research prioritization by identifying the most common medication exposures. In a retrospective cohort study, we used the Pediatric Health Information System database to identify infants developing severe BPD while admitted to United States Children's Hospitals. We then looked at daily medication exposures between 36 weeks postmenstrual age and discharge, or 1 year of age, whichever came first, and this defined the study period. We found that infants were exposed to a median of 30 different medications during the study period. And to put that into perspective, A 2014 study of pediatrics NICUs, which are more typical community NICUs in the United States, reported a median of 4 medication exposures per NICU patients. And a 2012 study of pediatric ICU admissions in FIS participating children's hospitals identified a median of 20 medication exposures. So in comparison, medication use is particularly high in the patients that we care for. Further, we found that the extent of medication exposures varied significantly by center. This graph shows an estimate of the number of medications an infant with severe BPD would be exposed to at various centers after adjusting for differences in case mix through multivariable modeling. And we found a greater than 2-fold difference between the hospitals at the extremes. Moving on to the second objective, what were the most common medications in infants with severe BPD? The loop diuretic, furosemide, was the clear front runner, prescribed in 1/3 of all patient days across the cohort, far more than any other medication. And this in turn is why I began to focus on furosemide for my own research. Diuretic use in general was very prominent. 3 other diuretics joined furosemide on the list of top 20 medications, including chlorothiazide in the second position. Diuretic combinations that you see here in position 20 is hydrochlorothiazide in combination with a potassium-sparing diuretic. Sedatives and analgesics were also common, with lorazepam, morphine, midazolam, phenobarbital, and acetaminophen occupying 5 of the top 20 spots. And not surprisingly, in addition to diuretics, various other medications directly or indirectly targeting improved pulmonary function and gas exchange were common. These included inhaled and systemic corticosteroids, such as budesonide and hydrocortisone, caffeine, the bronchodilator albuterol, and the pulmonary vasodilator sildenafil. So what is the evidence supporting the use of these medications? For lack of time, I will only focus on the top 5 respiratory medications: furosemide, chlorothiazide, budesonide, caffeine, and albuterol. And for each, we will restrict our review to data from the 3 highest levels of evidence: systematic reviews of clinical trials, and cohort studies. For each medication, I asked, in infants with severe BPD, less than 1 year of age, how does medication X compare to control with respect to physiologic or clinical outcomes reflecting pulmonary health or function? I restricted the review to infants with severe BPD because of all the factors that we just discussed, that our infants required tailored care that really differs from younger preterm infants with RDS or evolving BPD, or even milder forms of established BPD. So before we dive into the evidence, I do want to again emphasize that almost always we can't even be confident that we are using the medication just right. Pharmacology data specific to infants with severe BPD is scarce, and we have good reason to believe that the pharmacology is very distinct in this population. So keep in mind, in all of the evidence that I'm going to summarize, the effectiveness or lack of effectiveness of a medication may reflect a lack of therapeutic benefit, but it may also reflect a lack of optimal use. So for furosemide, my search identified 4 published trials enrolling a total of 47 subjects. And I will also review the results of a cohort trial that we recently published in the Journal of Pediatrics. Lily Cow and colleagues studied 10 subjects with a mean gestational age of 30 weeks and a birth weight of 1,400 grams. Infants had been on mechanical ventilation for 7.5 weeks, but at the time of study, the infants were on average 41 weeks postmenstrual age and were completely off ventilatory and oxygen support. So these may be healthier infants than the ones I commonly care for in the hospital in the chronic lung disease program. Using repeated measures in the same subjects, they compared furosemide 1 mg per kg IV to the same volume of 10% dextrose placebo. So compared to placebo, furosemide was associated with a transient improvement in airway conductance and pulmonary compliance, but this dissipated within 2 hours of administration. Hamendra Patel and colleagues studied 10 subjects with a mean gestational age of 29 weeks and a birth weight of 1,100 grams. Infants were around 7 months of age at study, and again were off ventilatory support, but did require an average FiO2 of 42%. This was a single-arm trial comparing outcomes before and after furosemide, first given as 1 mg per kg IV, and then as 2 mg per kg IV 24 hours later. So similar to Cow, they noted transient improvements in an RDS score and in PaCO2, but again, this effect dissipated. In contrast, they did not observe any improvements in oxygenation as measured by the AA gradient. Barbara Engelhardt and colleagues at Vanderbilt studied 16 subjects with a gestational age range of 27 to 32 weeks and a mean age of 10 weeks at study. Infants were again off ventilatory support, but required a mean FiO2 of 33%. So this design was a bit complicated. They essentially did a crossover RCT in 10 of the 16 subjects and a before and after single arm trial in the remaining 6 subjects, and then pooled the data. Furosemide was given as 2 mg per kg IV once, and then continued like this daily, or as 4 mg per kg per day orally for a total of 6 to 10 days. And infants in the control arm received normal saline once, followed by no further treatment. These are the results from left to right. Furosemide was associated with an improvement in total pulmonary resistance that progressed and reached statistical significance at 1 week. It was also associated with an improvement in dynamic lung compliance that progressed and was statistically significant at both 1 hour and at 1 week. However, these improvements in pulmonary mechanics did not translate to improved gas exchange, with an initial 3-point improvement in transcutaneous CO2 attenuating by 1 week of study. The same group from Vanderbilt published another study 4 years later, this time first authored by Dr. Margaret Rush. 11 subjects with a mean gestational age of 28 weeks and a birth weight of 960 grams were studied at 9 weeks of age, once off ventilatory support, but requiring supplemental oxygen. This was a stronger design. This was a double-blind crossover RCT of every other day oral furosemide, 2 mg per kg twice daily, versus an unspecified placebo, and each was given for 8 days. Furosemide therapy resulted in a statistically significant improvement in dynamic compliance and total pulmonary resistance, shown in panels A and B, respectively, but failed to show a statistically significant improvement in oxygenation. And just a few months ago, we published an observational cohort study in the Journal of Pediatrics. Though this study doesn't perfectly meet the criteria of our PICO search, it is indeed relevant to our question. We used the same FIS cohort I described previously, and we asked, how do hospitals vary in the extent of cumulative loop diuretic use among infants developing severe BPD? And how do low versus high use centers compare to each other with respect to mortality and age at discharge? After adjusting for differences in case mix between hospitals, we found a greater than 6-fold difference between the lowest and the highest using centers in the estimated proportion of days with a loop diuretic exposure, from less than 1 in 10 days to approximately every other day. And when we dichotomized the hospitals into either low or high use centers, we found that the adjusted mortality and the age at discharge were remarkably similar between the groups. And not surprisingly, infants at high use centers were significantly more likely to remain on a loop diuretic at discharge. In peer review, we were asked to repeat these comparisons, but by quartiles of use. And again, the only notable effect was that as use increased, the likelihood of remaining on a loop diuretic at discharge incrementally went up, without a clear impact on mortality or discharge timing. So personally, I would not take these results and interpret them as evidence that furosemide is useless, but it is further motivation for more rigorous study. Not only because efficacy is uncertain, but because harm is also plausible. So in summary, the existing evidence suggests that furosemide provides short-term and possibly longer-term improvements in pulmonary mechanics. However, it remains uncertain that this translates to improved pulmonary gas exchange. We should be cautious to make conclusions from observational data, but our recent findings raise questions about whether or not more furosemide use translates to improved mortality or an improved length of stay. Further, the presented trial data has various limitations. There were no clinically important outcomes reported. It's also worth pointing out that the data is old. The most recent trial was published 30 years ago. That's before antenatal corticosteroids, surfactant, and gentler approaches to ventilation became common in the United States. So you can really raise a question as to whether or not this data is even applicable to current infants with the new BPD. And further, all of these studies enrolled spontaneously breathing infants that likely had a lesser disease severity than many of the infants that we care for in NICUs today. What about the evidence for chlorothiazide in established severe BPD? I didn't find anything. What about budesonide? Again, nothing specific to our PICO question for older infants with established severe BPD. Ditto for caffeine. So presumably caffeine made our list because it was continued beyond 36 weeks in some infants with severe BPD on the basis of there being strong research evidence that caffeine is useful for preventing BPD. That said, the question of whether or not we should continue caffeine is not an unreasonable one and not one that we have data for. And lastly, albuterol. And finally, we have some more data that we can discuss. Haresh Kripalani, while at the Hospital for Sick Children in Toronto, studied 6 preterm infants born between 24 and 28 weeks of age. Infants were 7 to 15 weeks old at the time of the study and were ventilator dependent. This was a single-arm trial with infants studied before and after a single administration of 30 micrograms per kilogram of IV albuterol. All but one infant showed an improvement in respiratory system resistance, while all the infants showed an improvement in respiratory system compliance. Although quantitative data are not provided, the authors noted that there was no consistent change in gas exchange despite these improvements in pulmonary mechanics. More recently, Ed Shepard and colleagues at Nationwide Children's performed infant pulmonary function tests on 110 infants with severe BPD born at a median of 25.5 weeks gestational age and a birth weight of 710 grams. It is worth noting that only hospitalized infants with poor clinical progress were referred for PFTs. So this study, unlike most of the studies we've described, is a particularly sick group of infants, similar to those that we treat in the chronic lung disease program. So the objective of this study was to demonstrate that infant pulmonary function testing could reveal distinct severe BPD phenotypes, not necessarily to evaluate the impact of albuterol. However, they did test albuterol responsiveness in 93 subjects classified as having either restrictive, obstructive, or mixed phenotypes on the basis of their pulmonary function testing, and found that infants with the obstructive phenotype were far more likely to show albuterol responsiveness than those with the restrictive phenotype. So while these data do not provide evidence of albuterol effectiveness, this is great data supporting the idea that treatment response likely depends on disease phenotype, which is an emerging area of interest in BPD. Natalie Napolitano is a respiratory therapist and a clinical researcher at CHOP in our chronic lung disease program. She recently led a 3-period crossover trial in 22 infants with severe BPD. Infants were born at a median gestational age of 25 weeks and a mean birth weight of 610 grams. They were studied at a mean postmenstrual age of 49 weeks while on volume control ventilation. The comparisons were normal saline placebo, 1.25 milligrams of albuterol, or 2.5 milligrams of albuterol, and all were aerosolized every 4 hours for 24 hours with a 6-hour washout period in between. There were no differences noted for the primary outcome of absolute difference in expiratory flow at 75% of exhalation, reflecting what was happening in the small airways. The only statistically significant difference that was noted was a very modest reduction in the peak inspiratory pressure that was required to meet the set tidal volumes in the 2.5 milligram dose group relative to placebo, and a modest increase in the heart rate in the same group. So in summary, the existing evidence suggests that albuterol may provide short-term improvements in pulmonary mechanics, and raises questions about whether or not our dosing is just right, while suggesting that we need to be thoughtful about which patients we test. The benefit of albuterol in patients with severe BPD may depend on the underlying disease phenotype. So to summarize, neonatal pharmacology is particularly challenging because disease and development make infants with severe BPD moving targets. Despite this, medication use in severe BPD is very, very frequent, and yet the data to support our medication use is broadly lacking. I hope these data have helped you share my concern that the frequent use of medication in severe BPD, despite lacking pharmacologic or clinical research evidence, reflects an unmet public health challenge. So how do we move forward in the absence of evidence? Many clinicians want to know, well, what do we do? And am I suggesting that you should all go back to your NICUs and discontinue all of the medications? I'm not. Of course, I'm not doing that. But I don't think that all of these medications are useless. And we wouldn't continue to use them if we were convinced that this were the case. I think it's also worth highlighting that my describing an absence of evidence is not proof that these medications can't help, just that we haven't shown it one way or another. But all medications can cause harm. And I do think that there is an opportunity for far more cautious use in severe BPD and in neonatal populations more generally. So something that we have tried to do and that I would encourage all of you to do is before starting or continuing a medication would be to ask yourself, what effect do I expect this drug to have? If the drug has the intended effect, will it actually change the disease course in a meaningful way? When we start a medication, we try to ask ourselves, what can I clinically observe and ideally measure to help me decide if this medication is having the intended effect? If you don't think it's having the intended effect, I would encourage you to be brave and stop the medication. And lastly, I would encourage all of you to be a part of the answer. Developing high quality evidence with plausible effect estimates typically requires large sample sizes. And that is something that's hard to do even in common neonatal populations, let alone for something more specific like severe BPD, or even further for specific severe BPD phenotypes. And I am convinced that one of the major limitations in our progress in neonatology is that we do not have academic environments that incentivize broad scale collaboration to get answers to some of these unanswered questions and provide our patients with the evidence that they deserve. So I hope that in the future, we can all work together to try to answer some of these questions. And I'd like to thank you all for your attention and to everyone that has made this work possible, including my current funding. And I think we've left a fair amount of time for some questions. And I will stop sharing my screen. Come off here.
Thank you, Dr. Bamat. Thank you. And now the questions. Just a moment. How helpful is labeling early BPD in NICU management? How do we become absolutely sure it's BPD and nothing else?
Yeah, that's a great question. You know, and maybe let me step back and get a little philosophical and ask ourselves, what is BPD? I think you all know that defining BPD is an ongoing conundrum. I was a co-author on one of the more recent attempts to provide a better classification of BPD that I alluded to in the talk, and that is the NRN Jensen definition that classifies BPD on the basis of respiratory support rather than oxygen at 36 weeks. And we arrived at that classification through a data-driven strategy basically asking which classification is most predictive of the things that we care about, ongoing respiratory disease and ongoing developmental impairment at 2 years of age. But there has been historical and ongoing criticism that defining BPD by the treatments that we provide, as opposed to the underlying pathophysiology, is inherently limited, and it's impossible to argue with that logic. Ideally, rather than labeling a baby with yes, you have BPD or yes, you have evolving BPD, what we would be able to do is characterize the pathophysiology that is contributing to impaired gas exchange in that infant, and to be able to tailor our interventions, to tailor our management, to tailor our therapies to that pathophysiology, which will vary from subject to subject. Our group has done some more recent work looking at phenotypes of severe BPD, and we have developed an early kind of conceptual model that says, look, probably the three predominant patterns of disease are parenchymal versus vascular, and those infants that seem to have lungs that aren't quite as damaged as others, but seem to develop pulmonary hypertension, or airway disease, where there's specific lesions in the airway that are the primary cause of impaired gas exchange. So, saying, hey, I'm going to classify you as having early BPD may not always be particularly useful if it comes without an understanding of the lung disease that is evolving, of what that underlying phenotype is. And I would argue that trying to better understand the underlying phenotype in any given baby perhaps is a better approach to developing tailored therapies than giving an early label. I hope that answered the question. If it didn't, please feel free to unmute or to ask a follow-up question so that I can try to clarify that further.
I think that was a perfect answer. And in fact, we have to remember that in any disease, it is not important. Labeling is not important. What we have to understand is what processes are leading to the disease and how better we can manage this disease and stop whatever is going wrong in that baby.
Absolutely.
The next question is,
Role
what is
of,
the...
okay.
Yeah, please go ahead, Dr. George.
Role of vitamin A and vitamin E in BPD, and what formulation of vitamin A and E is available or used as in BPD at your setup?
Yeah, another great question, and another focus of great interest in neonatology. So I'll answer the question directly, and then I'll talk a little bit more about this topic. So in our NICUs, we do provide vitamin A as an intramuscular injection, and we restrict it to infants that are born at less than 1,000 grams, so extremely low birth weight infants. We do not use enteral formulations yet. I have seen some recent trials questioning whether or not there is a role for enteral formulations, and I think that's a topic that is deserving of further study. Vitamin A is tough, right? It's a very interesting topic because there was early evidence from the Tyson trial done by the NRN suggesting that vitamin A can be considered an evidence-based strategy for BPD. But subsequent observational data, including some natural experiments that were enabled by the lack of availability of vitamin A in the United States and other areas did not show a consistent benefit for vitamin A in the way that we would have expected on the basis of those early trial results. So is it that those results occurred at an earlier time and the patients that we're treating now are different, and so those results don't extrapolate well to that population? That's a possibility. A comment that I will make about clinical trials in general, without getting too deep into this rabbit hole, is I'm a member of the Society of Evidence-Based Neonatology, an executive board member there. I'm an associate editor with Cochrane Neonatal. I am a card-carrying proponent of evidence-based neonatology. I am a card-carrying proponent of randomized clinical trials. But I think it's very important that we not fool ourselves into thinking that the results of clinical trials generalize broadly often. I think we have to be very careful about interpreting results from a clinical trial in the context of the population that was studied, and to be very, very careful about presuming that effects or harms that we see in those trials also apply to off-target populations that weren't studied. Vitamin E, I can't speak to. It's an area that I would like to develop a bit more expertise on. I do not have it yet. We do not routinely use vitamin E in our practice.
Okay, thanks. The next question. Role of oral dexamethasone DART regime in BPD.
Yeah. Another great question on another challenging topic in BPD. I think we as a group are currently struggling with decisions about how aggressive we should be with the use of dexamethasone and with repeated courses of DART. So, I think we're all familiar with the idea that the pendulum has swung on many occasions with the use of dexamethasone, and there was a period in the not too distant past where there was a lot of use of steroids and dexamethasone and a lot of enthusiasm because they surely work. They surely help to reduce inflammation. They surely help to improve pulmonary mechanics. They surely help to improve gas exchange. I don't think that anybody would argue with that at a population level, but with subsequent findings that it comes at a cost, and that in some patients there's an increased risk for neurodevelopmental impairment, specifically cerebral palsy. The pendulum swung, and then there was a lot of hesitation, and in my mind, appropriate hesitation to use DART. But I like to refer to a paper by Lex Doyle that looks at a meta-regression and basically suggests that the benefit to harm ratio of dexamethasone really depends on the baseline disease severity of the population that's being studied, and that there's some sort of threshold value where if the lung disease is severe enough, the benefits likely outweigh the harms. And that is the approach that we take. We do try to use the NRM calculator to get a feel for what the likelihood of developing BPD is, and on the basis of that, deciding whether or not we use DART or not in the early postnatal period. And what I mean by the early postnatal period is really in that second, third, fourth week of life, when we're trying to make that initial push off of endotracheal intubation. What we struggle with in taking care of babies with severe BPD is not that first decision about using DART, but that decision as to whether or not we should use a third or a fourth or a fifth course of DART. One of the things that I mentioned is that we're a referral program, and oftentimes we will receive subjects that have already been exposed to multiple courses of DART in an effort to improve pulmonary function or in an effort to avoid the need to re-intubate. And we do think that it's important to be judicious and cautious about repeated exposures because it has a variety of harms. Adrenal insufficiency, for one, harms on linear growth and growth more generally, harms on metabolic bone disease, among other things. And so we do try to be judicious in its use, but many of us are starting to wonder if in these more severe patient populations, there is an opportunity for more aggressive use where there is benefit that outweighs the harms. And I think we don't know. And I think it's one of the areas that is ripe for study to look further and more aggressive use of corticosteroids more generally and dexamethasone specifically.
So in continuing with this question, you said that you use a calculator for calculating the baseline risk. So what percentage of the baseline risk do you take as a cutoff for starting corticosteroids? Is it 50 or is it some range?
So I'll admit that we do not have a fixed threshold. I would say that as a group, when we're in that space between a third of a probability to 50%, we start thinking hard about whether or not we would use DART. So, and it also kind of depends on the baby's postnatal age, but I would say that 33 to 50% is where we really start to think in this baby the benefit may outweigh that risk.
And how early do you start?
Typically in the second week of life. So I'd say that if we've gotten to 10 days, certainly by 14 days, and we are not seeing progress that would suggest that we will be able to trial extubation in the absence of something else, we will do it. So certainly if there's a baby that's 7 days of age, even 10 days of age, and we're in the midst of making nice progress and being able to wean the ventilator and the FiO2 isn't too high, and we're thinking, well, there's a chance here that we're going to be able to extubate even if we don't trial DART, we may hold off. But if we have a baby who seems to be stuck on the ventilator and non-responsive to attempts to wean, then that's a baby where we may start in that second week of life, as early as 7-10 days.
So you use dexamethasone as particular DART regimen, or there is some modification? And how many courses do you repeat?
So we use the DART regimen as published in the DART trial. We try to not repeat the courses. I think it's really in that, so right now I'm talking about more typical perinatal management when we're talking about a baby in the first few weeks of postnatal age. And if we can, we try to do it once and never again. That would be ideal. But at the same time, I must admit that for babies that fail an initial extubation trial, and are then re-intubated, it is not uncommon that we will try again. One of the things that we don't do, and this is just our practice, not suggesting that it's right or wrong, but one thing that we don't do, and we see some of our colleagues in neighboring community hospitals do, is to use dexamethasone in an effort to avoid a reintubation, in an effort to maintain non-invasive support. But on occasion, we certainly do have patients in our hands who have received 3, 4, even 5 courses of DART. Not because we feel that that's a good idea, but because the circumstances surrounding that baby were such that we felt that in that moment, the benefits could have been greater than the harms.
Thank you. Some of the participants have raised hands. Dr. Nargis, you can unmute yourself and ask question. Dr. Nargis, are you there? Dr. Nargis, you can ask your question.
Can I?
We have Dr. Dipti also who has raised an hand. Dr. Dipti, you can ask your question. Dr. Dipti, are you there? Dr. Georgia, you can move to the next question.
So this is Dr. Nargis.
Yeah, please ask.
Sir, I wanted to know about the role of restricted fluid in case of BPD.
Yeah, the simple answer is that I don't know. But I think that if you were to ask most neonatal providers why they use diuretics, I think the answer would be that it's an effort to promote diuresis and therefore reduce total body and pulmonary edema with the hope that that will improve pulmonary mechanics, gas exchange, and clinical outcomes. And I think it's very reasonable to ask, well, why couldn't we accomplish that and avoid a potentially harmful medication exposure through fluid restriction? And in my personal opinion, that is not backed by evidence. I think this is something that deserves further study. I think the idea of being more judicious with diuretic use and in favor, and instead of that, favoring more restrictive fluid is an interesting idea. That said, you run into some issues, as I'm sure you know. We think that nutrition, we will often tell our families, and this is something that we wholeheartedly believe in, that the most important treatments for the infant with established BPD is time and growth. And we see ourselves sometimes as the guardians of time, right? It's our job to try to do as little as we need to do to allow time and nutrition to do their thing and allow those lungs to develop and heal. And I mention that because growth and nutrition is the second piece of that broad view. And we often find that there's a tension between wanting to restrict fluid in our patients and at the same time wanting to give them optimal nutrition. And so my approach tends to be that I try to restrict fluid in babies with BPD as much as I can, particularly overusing diuretics, but working in close collaboration with my dietitian to make sure that we agree that we are able to provide adequate nutrition for that baby in doing so.
Okay, the next question for you. Is there a genetic predisposition as to which babies have more chance of landing with BPD?
Yes. The answer is yes. But the more challenging question that I don't have the answer to is which specific genes, right? And can we get to a place, and I think we will get to a place as the field advances, where we can do a panel of genetic testing in extremely preterm infants that gives us some useful information about that infant's predilection towards BPD, whether or not that baby is at increased risk of developing BPD based on a variety of data that come from doing genetic testing. I think it also holds the promise of helping us better understand the likely underlying phenotypes of BPD that a baby may develop. And from the onset, giving us a feel for what the likely outcomes may be and an opportunity to have more tailored therapies. So I think the answer is yes. I would assume that most of you would agree with that on the basis of the data that exists, but I think it's an important new frontier for BPD, and I don't think we're quite at a place yet where the reality of the answer being yes allows us to actually change our clinical care in a meaningful way.
Okay. And what is the ideal time to start furosemide in a baby with BPD, and for how long to continue it?
All right. I'm going to have to restrain myself here because this is what I study. So I have a lot of thoughts and opinions on this. So I want to admit my bias about diuretics and furosemide specifically. And in my heart of hearts, I believe that furosemide is likely useful for some subjects, used in a particular way. But I don't think that we currently know which subjects those are and exactly how to use it. So to answer the first part of your question, I think that ideally, the answer to when to use furosemide is never. If you can get away without using it, don't use it at all. I don't think it's something that should be routinely given to babies with BPD. That said, and this is not based on strong evidence, but my beliefs on the basis of the weak evidence that I have read and my own clinical observations in this patient population, I think the most appropriate time to use furosemide is in the setting of an acute or subacute exacerbation that leads to a worsening of a fluid overload status, okay? And that could be sepsis. That could be a PDA that for whatever reason has now become more hemodynamically significant and is worsening pulmonary edema, or some other form of insult that leads to an acute worsening in the baby's fluid status that may be contributing to pulmonary edema in that baby's lung disease. Now, the second part of your question, how long we should use it for, that is a question that I am actively trying to answer through some of my funding from NIH. And there is very good data from older populations, particularly adults with congestive heart failure, that show tolerance to furosemide diuresis, meaning that if you were to initiate many adults with congestive heart failure with furosemide, that they will have a robust diuretic response, but that diuretic response will attenuate over the course of just a few days. So I think we often make the mistake of giving furosemide to our babies, observing that they have a very strong diuretic response, saying that perhaps they've had some improvement in their mechanics and maybe even in their gas exchange, and thinking, great, this baby's a responder and it's worked. But what we don't do is to look at that baby 3, 4, 5 days later and ask whether or not they continue to have improvements in their fluid balance and their mechanics and their gas exchange 3 to 4 days out. And one of my research projects right now is trying to characterize specifically in severe BPD what happens to urine volume and fluid status over time once you start furosemide. And on the basis of that research, although we haven't proven it yet, I find myself falling into the tendency of trying to not use furosemide chronically, but rather to give it in short bursts of 3 days, 5 days, in an effort to try to help manage an acute problem, knowing that it's likely that my furosemide diuresis is not going to continue to be strong after a period of several days, and wanting to minimize the long-term chronic harms that can result from furosemide exposure.
Okay. Any role for intravenous hydrocortisone, low dose?
We use hydrocortisone frequently. We use it frequently because we take care of infants that have either known or suspected adrenal insufficiency. Oftentimes because they have a history of repeated exposure to corticosteroids such as dexamethasone. So we certainly use it a lot, and we find clinically that there are many babies that seem to be very responsive to hydrocortisone and seem to have deteriorations when you discontinue it. And so we often find ourselves in situations where we are very slowly weaning hydrocortisone in these babies over time. We do try to eventually come off of it. But I think as some of you know, there's recent data. I think the most notable trial is the Premilock trial, suggesting that there may be benefits to prophylactic hydrocortisone in extremely preterm infants. There's good arguments that all preterm infants have physiologic adrenal insufficiency and may benefit from low dose prophylactic hydrocortisone. There's been a recent publication within the last 2 or 3 years in Journal of Pediatrics doing a systematic review and meta-analysis of a variety of trials comparing low dose prophylactic hydrocortisone to placebo, suggesting that there is indeed a benefit for preventing death or BPD. And there are some centers that are using prophylactic hydrocortisone for this reason. That meta-analysis also shows that there are harms, such as an increased risk of intestinal perforations. And I think that we as a neonatal community, because of our history with dexamethasone, are very wary about the impact of corticosteroids on long-term neurodevelopment. And so I think another reason why many hesitate to adopt hydrocortisone is out of concerns that we will down the road find out that it leads to neurodevelopmental harms. Although I would say that the data that has come out thus far, although perhaps inconclusive, suggests that that perhaps the harms with low-dose hydrocortisone are not the same as you would observe with higher dose dexamethasone, as we have with DART trials.
Furosemide is known to work better as infusion than a bolus. What is your practice?
Yeah, I think it's a really interesting observation. It is not our practice right now, but one of the things that I'm trying to research is the pharmacology of furosemide, specifically in infants with severe BPD. And I think one of the things that that I touched upon but really didn't get into is this idea that furosemide clearance increases exponentially as infants age. And so what that would result in is a scenario where in older preterm born infants that are now several months of age, if the clearance of furosemide is far more rapid than it is in an extremely preterm infant in the first few weeks of life, where you will give a dose and it will have a therapeutic effect and kind of be in that therapeutic index for a brief period of time, and then the effective dose in the body will fall below the minimally effective threshold. And you will have potentially a long period of time in that dosage interval where you are effectively not treating with furosemide. And one of the things that I say frequently to my trainees is that the kidney takes its job very seriously. And the kidney has strong opinions on fluid and electrolyte balance. And there are redundant mechanisms in place for the kidney to try to achieve what it believes should be homeostasis. And so, again, borrowing from what is known in adults, we know that in adults, if you expose a subject to furosemide, and then there's a period of time in which the furosemide has come out of their bodies and is below the minimally effective concentration, that the kidneys will have will respond with rebound reabsorption. Well, they will increase their affinity to salt and water to try to make up for the salt and water that was lost while there was an effective dose of furosemide in place. And that especially if that is happening, if this rebound reabsorptioning is happening during a bolus of sodium, for example, in adults in a big sodium-filled meal, that you can completely negate the diuretic effects of furosemide if you don't dose it appropriately. And if you have these long intervals where you're below the minimally effective concentration. So I think this idea that an infusion of furosemide where you maintain a more steady concentration of furosemide within an effective window is a compelling one, and one that I think deserves further study in infants with BPD, but that is not our current practice yet. I think an extension of that would be, well, maybe we shouldn't be doing 1 mg per kg every 24 hours or every 12 hours, but we should be doing smaller doses more frequently so that there's a larger period of time where the drug is within an effective concentration. And that's something that we're trying to study and understand. And doing that may, especially if you do that with an enteral formulation, you could obviate the need for having an IV as you would need with an infusion. But there has been some research, especially in the CICU population that I'm aware of, suggesting that infusions are more effective. And I do think it's something worth studying more.
Okay, thank you so much. Thank you everybody for participating in this our masterclass series. Thank you very much for your interest and active participation. A special thanks to our speaker, Dr. Bamat, for this time and this outstanding lecture.
Thank you so much.
It was a great pleasure.
Appreciate it.
Thank you. Goodbye and see you tomorrow when we will address the topic common age disorders of adults and children. Bye.
Thank you so much, Dr. Nicholas. It was a pleasure hearing you and hearing from your experiences. You summed it very well and answered questions to perfection. If any participants wants to ask questions, kindly raise your hands before we call it a day. I would also like our panelist, Dr. Sitikant, to say a word or so.
Okay.
If we have no more questions or comments, we can call it a day. Okay, so thank you again, Dr. Nicholas. It was a pleasure hearing you, and we look forward.
Thank you so much.
We look forward to hearing you again sometimes in near future and in person.
That'd be great. Thank you. Take care, everybody.
Thank you.
Thank you all, and thank you Lucknow Neonatology Foundation for realizing this event. And thank you Professor Vijaya Mohan and Dr. Akash Pandita for giving us such precious opportunity to promote knowledge and improve newborn and child health across country.
Thank you